welcome back to our channel. It's Veronica. I'm missing my two ferns today and the candle. But today we're going to be going over rheumatic fever along with endocarditis and kind of differentiating between the two. So we're going to go ahead and start with rheumatic fever. And as you can see here, it typically follows strep, group A beta hemolytic strep. And so it's usually about 2 to 4 weeks after that initial diagnosis of that. And so what happens is the antibodies cross-react with the human tissue, and that leads to the rheumatic fever. And so a mnemonic to remember this as far as the criteria is Jones. So the J stands for joint involvement, and typically this is going to affect more than 5 joints. And then you're going to go ahead and move down to the O, and it kind of looks like a heart. You can see a dual heart next to the O, and that stands for myocarditis. So you have inflammation of the muscle tissue of the heart, and it's usually involving the entire heart. So you find that everything is inflamed, and this is a big thing that leads to our valve problems, so that's something to keep in mind. You're going to move down to the end, which is nodules. So you have non-painful nodules, and these typically only last for a few days and then they go away. You move down to the E, which is erythema marginatum, and I have this underlined with a star because this is a huge red flag that is associated with rheumatic fever. And so if you see this in a scenario or any type of questions, you're going to really want to associate that back to rheumatic fever. And those are just lesions on the body, typically the abdomen. And then you're going to move down to Sydenham chorea. This is abrupt involuntary movements. And so now we're going to turn over and look at the criteria. So Jones really helps you differentiate because it gives you those main points that are associated back to rheumatic fever, but there are different criteria that go along with that. So you have minor and major criteria. So with that, if it's initial episodes of rheumatic fever, you want to have 2 majors and 1 minor. And then if it's a repeat episode, it's the same criteria, but you also add on 3 minor. And so treatment for this, it's really revolving around symptom relief. So you want to give like an NSAID, you can give prednisone, and also you want to eradicate that group A strep. So you give a round of 10 days of the antibiotics, so penicillin is a great choice. And so now we're going to go ahead and move over to Shannon. She's going to go over the endocarditis for you.
Hi, this is Shannon. So we're going over these two together because a lot of people get them confused because you have kind of fever, some inflammation of a layer of the heart, and kind of just general vague systemic symptoms. So whenever you have rheumatic fever on your differential, you'll probably also have endocarditis on your differential. The really diagnostic factor that really distinguishes between the two is that with rheumatic fever, you have that strep throat infection. With endocarditis, we don't have any strep throat infection. So the way I remember endocarditis, I remember endocarditis because we use the Duke criteria to classify endocarditis. So with that, with the Duke criteria, you have to have 2 major, 1 major and 3 minor, or 5 minor. We have a kind of messed up way of remembering this, but take it if you will. It's 2 parents, a parent with 3 kids, or 5 orphans. So that's the 5 minor. We apologize. And then another way to remember endocarditis is I have this heart with a syringe going into it. This is super common in IV drug users. So whenever you think endocarditis, just remember that, or when you're working with this population, keep in mind that they could be susceptible to endocarditis. The valve that is most common is the mitral valve, except in the case of IV drug users, the most common valve is tricuspid. So remember, IV drug users try to do right. So that's the valve they're being infected with. In terms of bacteria, we have a couple different bacteria. It's dependent on whether you have your native valve or a mechanical or prosthetic valve, but I'll just go over a couple of them. It's more of our gram-positives. We have Staph aureus, Staph epidermidis, or Strep viridans, but know that there's definitely a couple other ones. So when we're looking at the physical exam and symptomology of endocarditis, you need to remember this phrase, from Duke to Jane. So that reminds you that we're working with the Duke criteria, and then we have Janeway lesions. So the from Duke to Jane, we have a little acronym here from Jane. So the F is fever, so you're gonna have a fever above 38. R are Roth spots. Those you're gonna see upon fundoscopic exam. I don't know what they look like, but know that it's a eye finding. And then O is oscillor nodes. These are tender nodules. M is murmur, so you can have a new heart murmur. And then J is Janeway lesions. These are also kind of nodules. The way you remember oscillor nodes versus Janeway lesions, the one very differentiating factor is that oscillor nodes are painful. So I remember Osler, ouch, whereas Janeway lesions are non-tender, non-painful nodules found throughout the body. A, anemia, N, nail bed hemorrhages. So think back, IV drug users, think if they have really bad nails, that may make you a little bit more suspicious for endocarditis. And then E, emboli, because if you have endocarditis, you're more susceptible to throwing clots, PEs. So the major criteria, like I've mentioned a couple times, the criteria, the major criteria, there's only 3. So it's going to be blood cultures. So you have to have 3 positive blood cultures drawn hourly, or 2 positive blood cultures drawn 12 hours apart. So kind of hard to remember, but if you remember blood cultures, that's probably good. And then E is echo. You need to have evidence of vegetation or the bacteria kind of growing in there in the endocardium on an echo, and then a new murmur as well. So those are 3 major. We're just not messing with minor criteria because who cares? We don't have time. It's too hard. And then treatment is going to be IV antibiotics. So that's going to be a couple long treatment regimen. So I'd assume maybe you need to treat these people inpatient. They're probably going to be pretty sick anyways. Yeah. So thank you for tuning in, and comment below.